Dr. Johnston is a well-known thoracic surgeon in the country. And he just retired very recently from the clinical service, but now he's the director, Beatrice Hunter Cancer Research Institute. He's also an executive member in the Lung Cancer Canada. And I was sitting in a chair, medical advisory team in Lung Cancer Canada. In addition, he's an Atlantic node leader, Terry Fox Cancer Research Institute. Dr. Johnston has led and involved many local, national, international lung cancer studies and clinical trials. And please welcome Dr. Johnston.
What I'd like to talk to you about today, we've all know that lung cancer is just a terrible disease. And so far today, you've heard from Drew and from Wojtek and others that there's some really exciting things going on in terms of dealing with lung cancer. And what I'd like to talk to you today is lung cancer screening, which has the potential to really change the face of the disease. In terms of actual cure rates, it has the potential of changing that dramatically. First of all, I'd like to just, Zalin said all my affiliations. These are them, and what I would like to point out to you a couple of things. The Beatrice Hunter Cancer Research Institute is an Atlantic-wide institute that enhances and develops the research agenda in cancer throughout the 4 provinces. And it's something that also helps to increase the number of cancer researchers in Atlantic Canada. And I'm very proud to be a part of that. The other organization that you probably haven't heard of that much before is Lung Cancer Canada. And that's an organization that started in Toronto. I've been involved with it for 15 years. And it's very much an organization that tries to support and educate people with lung cancer. And I don't know if you can see the websites there, but I would encourage you to take a look at those. You've already heard. Do I have a pointer or? That's what partners are all about, you know? You've already heard how bad lung cancer is. And this is a good graphic because it shows you this is the incidence, the blue, of the 4 major types of cancers that are prevalent in this area. And you can see that lung cancer is very common, but there's also a lot of other common cancers. But this in the black is the mortality, and you can see how difficult it is to treat lung cancer and how few long-term survivors we have compared to these other cancers. And this is where the big difference is in lung cancer and the area that we have to continue to improve on. And unfortunately, as you've heard before, Nova Scotia has the highest incidence, highest mortality rates for lung cancer of all of the provinces in Canada. This is a graph that's showing the relative survival ratios of lung cancer in various periods since 1995 all the way up to 2005. And believe it or not, there are 3 lines there, but you only see 1. What does that mean? There has been very little in the way of progress. All 3 lines are right on top of each other. And that's very disappointing for us who deal with lung cancer as we do on a daily basis. So we're looking for a way of improving those statistics, and this is something that you I think heard from Dr. Morzecki and Dr. Bethune a little earlier. These are the various stages of lung cancer, and we do pretty good in these stages. Where we don't do as well as in these stages. And so the trick is to diagnose more people in the early stages of the disease, and that's where screening comes in. Before you think of screening, though, you have to think of what the major cause of lung cancer is, and that's smoking. And so in any screening trials that we have, any screening program that you have for lung cancer, you have to think of smoking cessation as being a very major part of the program. And, you know, we've tried all sorts of things. These are the little stickers that were placed on cigarette packages. There's all sorts of ways of dealing with it, but unfortunately, we haven't been all that successful in getting the vast majority of smokers to quit smoking. But in terms of screening, you've heard this from Doug, who gave a great talk about our National Lung Screening Study that was sponsored jointly by the Terry Fox Research Institute and what's called CPAC, the Canadian Partnership Against Cancer. That was one of those Freudian slips, I think. And what I was going to say is that that's actually a federal bureau that has put money into a pot to try to get the best out of the cancer researchers in this country to see if we can make a dent on it. And this was a study that was done across Canada at these sites, including here in Halifax, to look at a method of screening for lung cancer. And this was the protocol, was we wanted to enlist 2,500 people across Canada, ages 50 to 75, and we used a risk index. What that means is we had a questionnaire, and Doug probably remembers that questionnaire, that looked at a number of different personal issues with a person, not only how long had they smoked, whether they quit smoking, what age they were, whether they had evidence of any other lung disease, that sort of thing. And we put that into a risk assessment strategy. And we come out with numbers saying this person has maybe a risk of 2% or greater of developing lung cancer in the next 3 years. And those are the people that we try to hone in on in terms of our screening. Now, why don't we screen everybody, ages 50 to 75, or every smoker, or anybody who's had smoking in the past? Well, the reason is we'd break the bank. There's no way of being able to do that. There's some other very good reasons, and I'll tell you that at the end of this, one of my points at the end. But the fact of the matter is we can't screen everybody. So what do? We try to get the high-risk group so that we can screen them. And you've seen CT scans. This is evidence of a CT scan. And the screening program looked at using what's called a low-dose CT. In other words, a CT CAT scan that is done with a much lower dose than a normal CAT scan. And we can pick up very small little nodules in the lung. And if this is a lung cancer and we resect that, we take that cancer out, instead of having about a 14 or 15% of being cured, which is kind of the cure rate across all lung cancers, this person has about a 77% to 80% chance of being cured. Quite a difference. So this is stage 1 lung cancer. And frankly, we do very well with stage 1 lung cancer. We do pretty well with stage 2. Stage 3 and stage 4 we don't do well with. So the trick is get them while they're early. In terms of the study, we did enlist 2,500 people across Canada, and in those 2,500 people, we've picked up 106 cancers so far. And this study's been going on since 2008. Here in Halifax, we've picked up 10 people, including Doug. He's one of the 10. And we still have a couple who are currently being investigated through these centers. But this, we were looking for about 2% of people that we screened developing lung cancer. We actually picked up over 4%, which, by the way, is higher than any other screening technique for other cancers, like breast cancer with mammography, PSA for prostate cancer, or colonoscopy for colon cancer. This is actually a higher detection rate. So does it really save lives? And what we can say right now is, yes, it does. And this was a U.S. study called the National Lung Screening Trial. You may have heard of these results back about a year and a half ago or so. And what they did was they took 53,000 patients, not patients, 53,000 people who were high risk. And again, they had a risk assessment tool also. And what they did was they randomized them. So it was kind of a flip of the coin whether an individual in this study either got a standard chest X-ray or a CT scan. And what they found, and they actually stopped the study early, they found that there was a 20% reduction in lung cancer mortality. In other words, 20% less people died of lung cancer if they got a CT scan versus just a standard chest X-ray. So we know now that lung cancer screening saves lives. We know that for sure. But there's lots of problems with screening and screening with lung cancer, and these are just a couple. First of all, if you're going to put your money into a big trial like this, many people would say if you put that same money into a smoking cessation program, it'd be more cost-effective, and that's absolutely true. The best way to deal with lung cancer on a global basis is to get rid of cigarettes. No question about it. Unfortunately, we've been trying to do that for years and years, and not only the U.S. government, but the Canadian government still support tobacco growth, farming. They still support letting cigarettes out on the market and tax it heavily, and you know the federal government makes money off of it. So that's one big problem. But another is a high false positive rate. And what we mean by false positive is, I believe Drew had mentioned earlier, if you do a CT scan on any of us, you might pick up tiny little nodules in the lung that are not lung cancer. And so sometimes these people can go through a number of different investigations, some of them being invasive, like needle biopsies or surgery or something like that, for something that actually isn't a lung cancer, okay? So what we found is that if you pick a high-risk group of people and you find one of these little spots in the lung, if they're in the high-risk people, it's much more likely to be a lung cancer than in somebody who is at low risk for developing lung cancer. So even in the high-risk group of people, we find a lot of false positives. And we have ways now of sorting that out as to whether a nodule actually is a lung cancer versus when it isn't a lung cancer. And that's kind of a very fertile area of research that's going on. Another thing, obviously, is the radiation exposure. Many people, you know, with lung cancer screening, it's not just one CT scan. It's a scan for a number of years. And if a small nodule, like in Doug's situation, are picked up, then they're going to get more scans. So there is a problem in terms of radiation exposure, and you'd like to limit that as much as possible, but that's one of the issues with screening. High anxiety. I mean, I was only at one table, but I'm sure everybody at these tables talked about how anxious they can be when they think that they may have a lung cancer. What about all of these people that are then found not to have a lung cancer? They still go through a lot of anxiety, so that's a different problem. Overdiagnosis is something that you don't hear about much, but it's a real worry to us researchers and administrators who are dealing with lung cancer, and that is that little cancer that we pick up in the lung, is that something that's actually going to be a significant medical problem to this person in the future? And a good example of this is prostate cancer. Prostate cancer, the incidence of prostate cancer is about the same as a man's age. So by the time a guy gets to be about 80 years old, there's a very good chance that they have prostate cancer. Is that prostate cancer ever going to kill them? Probably not. It's a very slow-growing, indolent disease. We know that this is also the truth in lung cancer. We always thought that a lung cancer is going to be an extremely deadly disease. It isn't all the time, and some of them grow very, very slowly over long periods of time. So we have to be careful of that. Lead time bias is another situation where if we pick this lung cancer up early, does that mean that it's going to have any difference to the overall effect of that person compared to if it was picked up late? In other words, do we have good treatment for it even if we pick it up early? Well, for the non-small cell lung cancer, that's true. We do have good treatment. For the small cell lung cancer, as Dr. Morzecki was saying, most of those, even if they're picked up early, have already spread. And what we found in our early detection study was the people with small cell lung cancer that we picked up in our early detection group, there was no survival advantage at all. And that was seen in the US study too. So these are some problems with screening. So it's what I'm trying to do is give you a balanced approach. Everybody says, yeah, it's best just go out and screen. Well, there are some issues. So we need more answers. And our study, the one that Doug participated in our national lung screening study, is wrapping up probably in another year, in next summer. So what we've done is we've petitioned the Terry Fox Research Institute, CPAC, and Lung Cancer Canada to support us for another year and a half. And the reason for that is there's some questions that we think we can answer if we continue to follow these people a little longer. How often to screen? In other words, do we have to screen people every year, or could we do it every 2 years? That sort of thing. How long do we screen? Do we screen them for the rest of their lives? Or there's some data now saying that if you screen somebody for 6 years and they haven't come up with a lung cancer, the chances are they never will. Can we further define who screening will benefit the most? And that has to do with this risk assessment I was telling you about. And there are some ways that we can look at. One is looking at biomarkers. Biomarkers are things that can tell us in more exact details whether somebody is at a high risk of developing a lung cancer or not. One of the biomarkers that we've come up with, it's no mystery to Lewis and his group at the Lung Association, is spirometry. In other words, just by breathing into a machine, if there's evidence of chronic obstructive lung disease, that person is at a higher risk of developing lung cancer. That's a biomarker, okay? What will be the cost? So at some point, we're going to have to go to the government and say, we need money for a lung cancer screening study. And they're going to say, how much is it going to cost us? So with our study, we're doing cost accounting on everything. And we should, within the next year and a half, 2 years, have a very good idea of how much it will cost. My own prejudice is that it isn't going to cost very much because most of these people that we screen and deal with at an early stage of the disease would have developed a late-stage disease and cost the system a lot more money. The last is what we call opportunistic screening, and that means somebody going to their GP and saying, you know, I've been a smoker for 30 years, I think I need a CT scan. That's the wrong thing to do, because the CT scan picks up things that you might need a lot more studies done. You might develop various complications from those studies in somebody who the risk of developing lung cancer was low to start with. So we need a program, and we need to do it right. So what's happening in Nova Scotia? We are probably the furthest along of any province in terms of developing a provincial lung screening program. The reasons are very similar to what you heard with the molecular medicine program. We have a very dedicated group of people in this province, and a small group. We're a small province, a small group, who can make things happen. And that's what's happening in lung screening, too. If you go to Ontario, everybody's fighting with each other. I've been in Ontario for many, many years, so I know this is how the system works there. Here, people are much more willing to work with each other, and I think for that reason, we're moving ahead at a faster rate. So we're looking at 5 different sites throughout Nova Scotia. We're setting up radiologists in all those sites who will be experts at looking at these low-dose CT scans. We have what we call the PACS system here, where every CT scan, every X-ray done in the province can be read by somebody centrally. We have a referral system where we basically have 4 thoracic surgeons. I used to be one of those guys, who see all of these patients. So there's a funneling in, and there's a certain expertise, and that's what you need for a good screening program. So I think it's moving ahead. I know it's moving ahead. How long it'll take to develop, I don't know, but we're getting a package together that hopefully we can present to government in the very near future. Thank you.
Thank you, Dr. Johnson. And we're closing on the end of our day today. It's hard to believe, Jalin, that the idea that you came up with not long ago is about to wrap up. But I think it's key that we don't consider this an end, but rather a beginning of something bigger and perhaps more focused. I've learned a great deal. I think our whole staff has. I want to thank our healthcare experts. We have leaders in the field of lung cancer care who have graciously led the way, and we're here today, so thank you for sharing. The passion that you have is obvious, and the partnership you're I guess, welcoming us to be involved with is something that I respect and appreciate a great deal, so thank you very much for that. Patients, sharing your experience, it's an intimate topic. It's very personal. It's very delicate, and some cases very raw and new. We don't take that for granted. But without knowing that and without learning more about what you're experiencing, either from a patient perspective or a supporter perspective, there's a lot we're going to miss. A couple of things that we gained, advice that we gained, and how important this is, are some of them are as follows. We were advised today to share our success stories. Like, it's not all doom and gloom. There's hope. There are good things happening. It's not like we're beginning lung cancer care now. There's all kinds of good things going on. We want to build on it. But share some of those stories, because there is hope. The thought of patient navigation to help people go through the system, I think, is pretty important and something we have to take a look at. Support groups. We have a COPD support group. What about a lung cancer support group? We know how to do that, and it's something that can be done. Not a lot of money involved in that. It's a little bit of effort and some marketing, perhaps. Early detection, of course. We've heard from many speakers the value of that. Where that fits into a strategy or an overall plan is something that has to be considered, and why not bring the world's best method of early detection here? Once we really get onto it, maybe we can generate more funds, more support. I don't know. But if we don't try, we know what the answer will be. The concept of the stigma, mostly involving tobacco use. And I said it at the opening, like once you're diagnosed, who kind of cares? It's about being compassionate to our next door neighbor or brother or our father or mother and doing what we can. Because there's a quality of life to be lived until it's over. And that's what we have to be a part of. So that stigma is something we're going to deal with. And also the timely results and where that fits into the whole puzzle. What comes first is a question. You know, usually it's sort of advocacy, public awareness, then early detection, and so on, prevention. There's a whole range of things. We want to look at this puzzle as a whole, and see what we can do to impact lung cancer from the logical start to the obvious finish, so that we can make people's journey in life better. And that's kind of what we're trying to do from a lung association's perspective, and I think we found a whole lot of partners that are thinking a very similar way. Key is to engage a broader group. The patient and support group, as tough as it might be, you can't sit back. You've got to get engaged and you've got to get involved. People do not support movements, they support people in movements. And I'm a guy at the Lung Association, your brother. Your story is powerful. Your father, yourself. It's powerful. And people really care. We just have to present it in a way that allows them to come in and to show support. Governments will not fund things that we don't have great evidence and great passion and organization behind. They've got 200, 300 people banging at the door. And it's the groups that are organized, that present the facts and prevent solutions, usually cost-effective solutions, that are going to get support. And it's our tax dollars. It's our tax dollars. We just have to present it in a way that we want our share, because this cause deserves it. Doug said earlier, it is what it is. It is what it is, and it is something that needs attention, and we have a lot of people that want to give it attention. It is what it is. We know there's stuff that needs to be done on lung cancer, and we're going to get at it. We're going to we want to build a strategy that deals with the whole deal and comes up with solutions that we measure so that we can prove it's worthwhile. As a taxpayer, we should prove it. We can't just throw money at it, we have to prove it. We can do that because we have a lot of smart people involved. And Anne Marie asked, her doc friends, just don't give up. Don't give up on us. Don't lose hope, don't give up on us. Well, it's clear the medical leaders aren't giving up on you, and because of the passion. And we're not going to give up on lung cancer patients either, and maybe we're just starting. It's not that lung cancer care is just starting, but perhaps maybe a bigger movement is just starting, and maybe today will go down as a big day. A day that we all say, you know what, we were there and it's better now, and better in a year than it was then. And good things come from small beginnings. And I'm thrilled to have been involved in today, but it's just a start. I thank everyone for your involvement. If you have anything that you want to share with us, you can call us, email us. My number, my cards are here. Get us on the internet. Just do it. Any ideas, advice, please do. If you have friends engaged in the movement, please reach out to them. We're going to be back in touch with you on a next step, and there will be. And we need you and appreciate you being here today. We'll wrap it up, and thanks to everyone. See if we can do something about lung cancer.